Thank you very much for your kind words. I would like to thank on my behalf Dr. Sparias and Mr. Patakos for this kind invitation. So my talk will be about TAVI for severe aortic regurgitation. So first of all, so I'm pressing the arrows. Okay. Okay. Severe AR is not so uncommon as we probably think. It's something that does exist, and definitely we need to pay more attention. So we can appreciate that pure severe AR is definitely less common compared to severe aortic stenosis, but it's still there, especially in older population. So how these patients are doing, and if we don't do anything, so we would just do a conservative approach, and we can appreciate that probably is a bit more indolent course compared to severe AS, which all know that mortality rates are around 50% in 2 years. This is a 10-year course of the disease, and however, we can see that this mortality inclines steeply in patients that are decompensated. So with a functional class of 3 or 4, we can see that at 5 years the mortality rate is approximately 70%. So does intervention associate with better outcomes in these patients? Definitely does. And it seems that early intervention is much better than later one, and we can appreciate that the prognosis in patients with functional class 3 or 4 is worse compared to those one with less symptoms. So what are the guidelines say about treating severe AR cases with a transcatheter approach? Definitely are not favorable for this approach. It's a class 3 according to the American guidelines. However, is recommended that is rarely feasible and inhibitive surgical risk, subject of course to appropriate anatomy based on the annular size or some annular calcification. And why is that? So this is a big registry from the US that has shown that patients that undergo transcatheter intervention for severe AR are doing much worse compared to ACE cases. We have higher rates of device migration and embolization, higher convention rate to surgery, and a higher rate of re-intervention. In fact, the 30-day mortality rate is about 15.5%. Now, regarding the performance of the already available devices, so we can see that the early generation devices are doing much worse. We have higher mortality, higher residual paravalvular AR, and rates of device migration. The new generation devices are doing slightly better, but again, the rates are pretty high. And another thing that we should pay attention is the residual AR that in rates of at least moderate severity is associated with much worse prognosis compared to mild or no AR. So what are the challenges that we're dealing with when we consider a transcatheter approach in aortic regurgitation, pure aortic regurgitation? So essentially the main problem is insufficient anchoring, and essentially this is related to the significant lack of calcification in the annulus and the valve leaflets. Large annulus that we often see in patients with severe AR. And of course, the insufficient anchoring is associated with further repercussions, including higher risk of dislocation of the valve, higher rates of residual aortic regurgitation, and because of transcatheter heart valve oversizing, a risk of annular rupture. Another consideration is the suboptimal fluoroscopic visualization because of the lack of calcification, which is a bit challenging when we're trying to position the valve. So what are the anchoring mechanisms? So these are different based on the actual platform that we use. So for the self-expanding valves, we have two sides of anchoring. So one is the annulus, and the other one is the side where the frame outflow of the valve is reaching the wall of the root. So if the frame is in touch with the root, then this can give an additional friction that could improve the anchoring. For balloon expandable valves, the only side is the annulus. And for the dedicated devices, apart from the annulus, we also have anchoring mechanisms regarding the leaflets. So what we know so far about the performance, especially of the conventional platforms, so we can see that the 30-day mortality is almost prohibitive. So in some case series is almost 23%. We have significantly higher rates of residual aortic regurgitation, moderate or severe aortic regurgitation, almost 20%. And we have, of course, higher rates of embolization. However, the most recently published ALIGN-AR study that evaluated the efficacy and the safety of the JENA trilogy valve showed very promising results that approaching the rates of TAVI in AS cases with a 30-day mortality of only 2.2%, residual moderate AR of severe AR of only 0.6%, and rates of embolization of only 2.2%. But of course, that was the trade-off with a higher rates of new pacemaker implantation of 24%. So this is the trilogy valve. It's a nitinol frame, self-expanding platform with a porcine pericardial tissue. We can appreciate the three large cells that facilitate coronary access post-implantation, and also the three locators for the commissural alignment. The valve is delivered through a pre-shaped 18 French sheath, which allows the torquing of the device in order to achieve proper commissural alignment. So the valve is positioned and deployed in three stages. So first we perform the alignment based on the three locators. Then the locators clip onto the native leaflets. So in order to achieve a natural seal and stable securement, and finally we deploy the valves and facilitate the coronary access with the big cells. Now, I will present a case very briefly. This is my British experience, a case I performed my British colleagues at St. Thomas's Hospital. This is a 76-year-old lady, quite frail, quite symptomatic, with a functional class of 3 or 4. Many comorbidities, and the transthoracic echocardiogram showed reduced LV systolic function with moderate severe aortic agitation and also pulmonary hypertension. We can appreciate here the severity of AR. So this case was discussed in the local heart team meeting, and the consensus was for a transcatheter approach, subject, of course, to appropriateness of the underlying anatomy. So here's the CT scan. We can see there's a lack of calcification. We can appreciate the thickening of the valve leaflets. In terms of annular size, there's a perimeter of 79.1 millimeters and almost equal size LVOT. And good sizes of the sinuses of Valsalva, and also STJ diameter and height. And the coronaries were pretty good as well. Coronary heights around 15 millimeters. So we opted for 34 millimeter evolute effects and with oversizing of approximately 30% based on the annular measurements. These are the legs, so small vessels, but without any significant disease. So we went with dual transfemoral access, so right transfemoral access with insertion of the A-line sheath of the valves. Here we can appreciate the setup shots, 3-cusp view, and overcusp view. And here we start the deployment. So we perform this with a pacing around 160 BPM. So, and trying to stabilize the device as much as we can and start the deployment, and also using a Lindquist wire just to facilitate the deployment and achieve a better stability whilst we're deploying the valve. Here the depth, we're a bit deeper than we want to, so we do a bit of recapturing. Here the depth is a bit better. And finally we release the valve. And this is the LAO views. Even though at the final view you can see the bit of diving of the valve, but without migration. And this is the final echo. And we can appreciate no residual AR and good hemodynamics. So in conclusion, TAVIs were essentially designed for the treatment of degenerative calcific aortic stenosis. However, it can be used off-label in selected cases with pure AR, with prohibitive surgical risk and appropriate anatomy. The clinical results are, however, variable, slightly better outcomes with the next generation devices. In these cases, the design of the transcatheter heart valve is paramount, and there is a need for a dedicated anchoring mechanism. And the Trilogy valve introduces some unique features and is the first of its kind dedicated transcatheter heart valve for the treatment of pure AR that has received a CE mark for this condition. Thank you very much.
Thank you very much, Andreas. Fantastic talk. And I would like to ask Dr. Roubellakis if he has any comments, and then unfortunately we have to proceed with the last presentation. Dr. Roubellakis, please.
Excellent talk, and thank you very much, Dr. Kalogeropoulos. It's just going to sum up and say that we still don't have the technology for aortic regurgitation. It's a different set of patients. The peak age is between 40 and 60, and younger patients with low surgical risk. So before we reach the point where we can discuss about options with aortic regurgitation, we still have a path to follow and a mountain to climb made for these patients. Thank you very much.
Thank you very much, Andreas. Thank you very much, Dr. Roubellakis.